That's good.
Okay, so today's podcast is on electrical stimulation therapies for chronic pain and related distressful conditions. And my guest is neurosurgeon Dirk de Ridder. He's a MD and a PhD. He hails from Belgium, where he is now, but more recently he's moved to New Zealand, spends a lot of time there at the University of Otago. And he's pioneered many different stimulation techniques, both non-invasive and invasive, implanting electrodes in either spinal cord, or I guess some cases in the brain itself, for chronic pain and other disorders. He's co-founder of a clinic in Ghent that works with patients, and he's published extensively on this, on his experience and outcomes with these. So welcome, Dirk.
Thank you, Mark.
And so in your webpage, your summary of what you're doing in one short line is understanding and treating phantom perceptions. So in the case of chronic pain, of course, pain is a natural thing that helps us survive and avoid things that can hurt us, damage tissues, and tissue damage, inflammation can excite the sensory neurons that provide inputs to the brain. But there's a lot of evidence now, and I think it's pretty well accepted, that with chronic pain, there's actually alterations that are occurring in neural networks in the brain. And Dirk's trying to understand those networks and how to kind of normalize them so that the person doesn't suffer, right? Because the big thing with chronic pain is persons perceiving they're in pain, they're suffering, they can't focus on their work or can't do things they'd like to do without the pain. Okay, Dirk, so can we start with your background? You grew up in Belgium, and I understand both your parents were professors at University of Ghent, is that correct?
Yeah, so I come from an academic family. My father was a professor of histology at the University in Ghent, and my mother was a historian working first at the University of Amsterdam in the Netherlands and later in Belgium. So I guess I was kind of predestined to take up a family tradition. And although initially I started as a clinical neurosurgeon before, I guess some genetic push drove me into academics after all to join the family tradition. But it was most of my research has been clinically informed or inspired because I'm not a basic scientist. I've done clinical research basically my whole career. So doing clinics and doing surgery was where I got most of the inspiration for trying to solve practical questions, mostly clinical questions. And how can we improve tinnitus? How can we improve pain? How can we work on looking at the analogy between physical pain and psychological pain? Can we learn from one to treat the other, etc.? So yeah, it's all practically and clinically informed.
And can you talk about the kind of this three systems or pathways for chronic pain?
Yeah, so from a very practical point of view, when somebody comes to see the clinician with pain, it's not because the person feels painfulness, because painfulness does not have to result into suffering. For example, my youngest son is a judoka, and in the evening when he doesn't feel pain, he's actually unhappy because for him it means he hasn't trained hard enough. So pain for him is not suffering, it's something that is beneficial. And we know from other contexts, for example, in an erotic context, that some people might even like pain. So suffering is ultimately what drives the persons to come and see us, which means, and this is dissociatable from painfulness. And so from a practical point of view, we have what we call a lateral pathway, and the lateral pathway, which is predominantly triggered by A beta and A delta, but also a little bit by C fibers, but all by the high threshold fibers that go to the lateral nuclei of the thalamus, and therefore the name was developed lateral pathway. And from there, it's related to the somatosensory cortex and further to the parietal area, etc. So this is a pain dedicated pathway that we have, and as you mentioned before, pain is also a physiological mechanism that that tries and prevents us from getting too much damaged or running away from a painful stimulus. But pain can, but does not have to be associated with what's called activation of the medial pathway, and the medial pathway is uniquely activated by C fibers. So unmyelinated C fibers that basically encode pleasantness and unpleasantness. So in general, you can say that the low threshold C fibers create pleasantness that is activated by gentle caressing or stroking. And that one, there is high threshold C fibers that then activate unpleasantness, rather than what I was taught in medical school, that A delta fibers create the sharp pain and the C fibers, the dull, late pain. It's probably a little bit different with what current science suggests. Now, these C fibers, they go to the medial nuclei of the thalamus, and hence the name medial pathway, and from there to the anterior cingulate cortex and the anterior insula. Now, what's interesting is that this is a non-specific pathway. It used to be called a pain matrix, or it had other names, but ultimately it's a salience network pathway, or salience network, as it is defined in cognitive neuroscience, where they look not just at pain, but also at other stimuli, and where the medial pathway, as defined in the pain literature, overlaps strongly with the salience network as defined by cognitive neuroscientists. And this, of course, makes sense, because pain usually is salient. I mean, pain has a behavioral value to get away from the painful stimulus, but also, and that's the top-down salience, but also you can have bottom-up salience, where a painful stimulus is very different from simultaneously gentle stimuli. So it's also a bottom-up distinctiveness that can be conceived of as salience, and that will activate the salience network. Now, these two networks, the lateral, which is pain-specific, and the medial, which is non-specific salience pathway, that when it becomes associated with negative cognitive and emotional responses, we call a suffering pathway. These two are counterbalanced by a pain modulating or a pain inhibitory pathway that involves predominantly the pre-general anterior cingulate cortex, goes from there to the reticular nucleus of the thalamus, the periaqueductal gray, down to the rostroventral part of the medulla oblongata, and will then prevent further input of painful stimuli. So ultimately, pain is a balance. It's a balance problem between input from the lateral pathway that is associated with or without suffering from the medial pathway, and the descending inhibitory pathway. Now, we looked at that with EEG, and what is interesting is that, of course, there is activity differences, but the activity differences that we find on a meta-analysis of functional imaging in pain shows that global pain actually is associated with activation of the periaqueductal gray and the rostroventral part of the medulla oblongata, meaning with pain inhibition. So neuropathic pain shows the signature has part of it is pain inhibition, which suggests that it is a balance problem where you got pain input, but if the pain suppression is increased, but less increased than the input, you'll still have pain. So this balance idea then is also confirmed by other studies. For example, if you put an electrode on the spinal cord and you stimulate, then the amount of pain suppression you get is correlates with the Bolt signal, so the activation of the pregenital anterior cingulate cortex, meaning how well you can activate this pain inhibitory pathway to rebalance this pain. We've shown the same thing with EEG. And then the question, of course, is where's the trigger? Why do some people develop chronic pain, and why do some people not develop chronic pain? And so we try to look at that in those three pathways again. And what is interesting, based on functional connectivity, meaning another measure of looking at brain functioning. So instead of looking at activity, which is more or less related to whether parts of the brain are shouting or whispering, we're looking at communication using functional connectivity. And what is interesting is that in chronic pain patients, in comparison to healthy controls, so people without pain, that these three pathways don't seem to communicate very well. The functional connectivity is decreased, which means that those three pathways do whatever they want, but it also means if there's no communication, there can't be a balance. And so the pain inhibition can't compensate for the input. And this is probably, and then when you put a spinal cord stimulator in and you activate it, what you see is that the communication re-engages. So the pain inhibition and the pain input pathway start to communicate again, which can recreate the balance so that the pain can go down. But
So
then, of course,
where in the spinal cord do you stimulate? And what, so are you stimulating the descending inhibitory pathway when you stimulate in the spinal cord?
That's a very good question. Actually, we put the electrodes on the dorsal part extradurally. We assume that for classic tonic stimulation, you modulate the dorsal columns, and we don't really know, to be honest. But that's the assumption. So the assumption is that.
So you have the sensory neurons, their cell bodies are in the dorsal root ganglion, right?
Yeah.
And then they have ascending axons going up to the thalamus. But
yes. So
would you get the same benefit by stimulating the DRG directly?
Yes. So it has been shown that if you put an electrode on the DRG and you stimulate the DRG directly, then of course in a dermatome specific way you can influence the painful stimulus going to the brain. So that works equally well as spinal cord stimulation. It's technically a little bit more challenging because of but it does work very well for pain suppression. And of course,
but in that case, then you're getting, as you mentioned, dermatome-specific suppression. I guess if you're stimulating the dorsal column, which is axons from a number of different dermatomes, you'd have more widespread effect or not?
A little bit, yes. But you should not forget also that the DRGs do communicate via the rami communicantes. So sometimes you can have more than one dermatome as well, even though you stimulate one DRG. But in general, yes, you can say it's more dermatome specific. However, depending on, so usually when you stimulate the spinal cord, it is higher up. It's at somewhere in between T7 and T10. And you can, depending on which poles you activate, then you can also be more or less dermatome specific. Now, normally with tonic stimulation, what you do is you activate A beta fibers. And this is based on the pain gate theory that was developed in the 60s, where we know that if you have damage of, let's say, the the larger fibers, then the high threshold C fibers start firing spontaneously, and this could be the trigger for pain. So that when you activate those A beta fibers, they will suppress those C fibers, and that then is associated with an improvement in pain. However, it comes at a cost, and the cost is that you have paresthesias. You feel tingling in the area where normally the pain is going to be. Now, what's very intriguing is that when Maarten Moens, a researcher in Brussels, put patients with a spinal cord stimulator in an fMRI scan, is that it modulated the thalamus and the somatosensory cortex, but not the anterior cingulate and the dorsal part of the anterior cingulate and the anterior insula. So it was only modulating this pain-specific lateral pathway. And as I mentioned, the clinical benefit came from how well it activated the descending pain inhibitory pathway. So this traditional tonic stimulation only seems to modulate the lateral painfulness pathway and the pain inhibitory pathway, but unfortunately not the suffering pathway. And this is where when I developed burst stimulation, we were actually surprised to see that it also modulates the suffering or the medial pathway. And the way we looked at that is, instead of doing it in an fMRI, we did EEGs with the spinal cord stimulator on in tonic, spinal con. We recorded with the spinal con stimulator on in burst. We recorded with the spinal cord stimulator in placebo. Then we subtracted placebo from burst, we subtracted placebo from tonic, so we knew we were only looking at stimulation-induced effects. So, and then we could compare it. We did a conjunction analysis, so we were looking at what do they have in common, tonic and burst stimulation, and what they had in common was very unsurprising, because they both treat pain, is that they modulate the lateral pathway and the descending pathway, which is perfectly to be expected, of course. But then when we subtracted the data, when we wanted to see, okay, what's the difference? Actually, what we saw is that the difference was in the rostral to dorsal part of the anterior cingulate cortex, which we know already from a famous study by Rainville and Sines in the 1990s, that it correlates with the unpleasantness, with the suffering. And this is interesting, because now by just changing the language that you use to communicate with the spinal cord, you can also modulate the medial pathway on top of the lateral and the descending pathway. And this, of course, opens up
for the burst stimulation. So you do like a burst, very rapid stimulation, then a pause, then another burst. Is that what you're doing?
Yeah, but the critical idea here is that physiologically, a burst is a group of high frequency monophasic spikes that rest on a plateau which is calcium mediated, usually via T channels. So, and that's intriguing, because the normal tonic stimulation mimics tonic firing, and tonic firing just involves sodium and potassium spikes. Now, with burst stimulation mimics burst firing, and this burst firing, normal, well, depending, there is some semantic confusion, but true burst firing, as has been well studied in the thalamus, involves influx of calcium, and that creates a kind of a plateau, and then you got the sodium potassium spikes on top of that. Now, you might say, why is that important? Why would calcium be important? And it is because calcium is, from an evolutionary point of view, the oldest salient signal, or the oldest danger signal. For example, if a caterpillar eats bites a leaf of a plant, that from there you will get a calcium signal that goes to the adjacent leaves, where it will activate the DNA to produce toxic products that are released, so that the caterpillar, when it gets to the next leaf, will say, oh God, this is disgusting, I'll stop eating. So it's a nice defense mechanism, but plants can't move, so they've got time. So this is too slow for mobile creatures such as we are. And therefore, I hypothesize that it's crucial that this calcium signal was embedded in a firing pattern that is ultimately just an electrophysiological signal of salience that says, look, something important is happening, and could be good, could be bad. And that's why this calcium controlled burst firing is present already in the lamprey, which is ultimately the evolutionary oldest organism with a brain which is somewhat similar to ours. And so it's a universal language, and you'll find it in the DRG as you hinted at.
So since I retired from the NIH, I wrote a couple books, and the most recent one just came out. It's back here. It's called Sculptor and Destroyer: Tales of Glutamate, the brain's most important neurotransmitter. And I have one of the early chapters is on evolution and, early roles of glutamate. Maybe the first transmitter, actually. It's a simple amino acid, but of course I talk a lot about calcium in there. And so have you looked at, well, so you're doing human work. I guess you'd have to use animal, but so what you're saying is with this burst stimulation, you're getting elevation of intracellular calcium, and that's activating maybe CREB or some transcription factor that then causes some neuroplasticity.
So the way I look at it is that what is hypothetically happening is that when you activate bursts, whether you do that on the DRG or on the dorsal horn, indirectly in lamina 1, where you find a lot of this burst firing, then the question, of course, is what are we truly doing? So what's interesting is if we give an extremely low threshold for the stimulation, so we really give very, very little stimulation, my hypothesis is that we activate predominantly tactile C fibers, which are antinociceptive. So this might be an entirely different mechanism of action than what we know tonic stimulation does. And and those tactile C fibers, they burst. And so the hypothesis is that what's intriguing also, if we increase the amplitude of the stimulation, you will also start activating high threshold C fibers that create unpleasantness. And this is exactly what the patients tell us. Look, if you increase the amplitude, maybe the painfulness drops, but I truly dislike this stimulation. It's not nice. It causes a sympathetic arousal actually in some of these patients, where they say, I get palpitations, I become irritable, nervous, I get headaches. And if you drop the amplitude, that disappears. So my hypothesis is that because of that, we have to use as low an amplitude as possible, and also don't stimulate constantly, but go and stimulate intermittently. Just like you would have, it's like when I talk to my children and shout all the time, they say, well, Dad is shouting. It doesn't really, they should, and they stop. Nothing is important anymore. But even if I don't shout, and I just say constantly, it's important, it's important, it's important, well, it also loses importance. So I think we have to stimulate as little as possible using this non-scientific metaphor. But it would suggest that we might actually need to investigate this in an animal model to really show that this hypothesis might be correct. Clinically, we know if we use burst stimulation, we don't create an A-beta evoked response. So A-beta fibers are not involved. Furthermore, in the nucleus gracilis, we don't see any changes with burst stimulation. We do see that with tonic. And with tonic, we do see this A-beta fiber activation, which is being used by a medical company to do closed loop spinal cord stimulation, but you don't see that with burst. So there has to be another mechanism of action. And the fact that we have to use these low amplitudes and that it is antinociceptive suggests that we might be actually activating those tactile C fibers.
So you mentioned the anterior cingulate cortex in this medial suffering pathway. Yeah. And that's part of the default mode network, is it?
Well, no. And
okay.
So no, it is actually more related to so it's the more dorsal part to rostral to dorsal part. So so maybe I might have misexplained, but the default mode has predominantly the pre-general anterior cingulate cortex extending into the ventromedial prefrontal cortex, combined with the posterior cingulate, then the temporoparietal junction and the anterior lateral part of the temporal junction. Now, this medial network is anti-correlated with the salience network. So the salience network involves is basically the same as the medial pathway. So the rostral to dorsal part of the anterior cingulate with the anterior insula. So when your default mode is active, then normally you're just mind wandering, thinking about the past and the future. It means there is nothing of behavioral relevance occurring in the environment. When this happens, of course, when your phone goes off, when somebody shouts fire, something in your brain has to tell you, look, you have to switch your attention. And that's where the burst firing comes in. That activates your salience network or your medial pathway, and your attention will, and because it is such a strong activator, it overrides ongoing tonic activity so that you can shift your attention to the new, more behaviorally relevant stimulus. And I think this is what we seem to be doing with burst stimulation, that we modulate this salience network. Now, the salience network, when that is active, it will co-activate what is called the central executive network or the frontoparietal control network that will then initiate goal-oriented behavior. I mean, picking up your phone and answering the phone, or looking where the fire might be. And these are correlated. So the salience network and the central executive are correlated, and both of them are anti-correlated with the default mode. Now, what's intriguing is in chronic pain is that the pain becomes linked to the self. I mean, the pain becomes part of who I am. And this is probably because the default mode network overlaps with the parasympathetic rest and digest and restore system, whereas the salience network overlaps with the central control of the sympathetic system. And this, of course, consumes energy. And so in acute pain, what happens is your energy expenditure goes up by 60%, which is unsustainable. I mean, nobody can sprint a marathon. You can run it, but you can't sprint it. So what's happening is that from an energetic point of view, your brain might say, look, if the pain is there longer than it should, I'll just link it to my self-percept, which is overlapping with the parasympathetic system, and thereby you save about 35% extra energy expenditure by going to the default mode state. And interestingly, we still have to publish the data, but we're writing up the paper now. In chronic pain, what you see is that the somatosensory cortex, so the painfulness pathway, becomes linked to the default mode network and not directly to the sympathetic system. So it seems to be that this idea that the pain becomes part of who I am, because that's what the default mode does, has an energetic profile, so that in chronic pain, you still consume more. You still consume about 15% extra energy, but that's running a marathon. That's not sprinting it anymore. So so these interactions in the brain are actually very logical and make a lot of sense from an evolutionary point of view.
Yeah, it does make a lot of sense. Now, people with chronic pain, often they, have feelings of anger, they have anxiety, and can lead to depression. So how do you kind of envision the circuitries that are traditionally associated with anger and anxiety and depression? So the amygdala, we haven't mentioned the amygdala yet.
Yeah. So so what you have when you are chronically, call it stressed, when you're chronically stressed, you start shutting down your pre-general anterior cingulate cortex, which is the pain inhibitory pathway, which is problematic. But you also start activating your amygdala, which then becomes linked to the orbitofrontal cortex in chronic stress. And so basically what's happening is that your brain is trying to is connecting the salience network to the amygdala and the orbitofrontal cortex, and this then creates emotions and mood states. And the problem there is that this link then becomes, so the suffering becomes more specific. It becomes either depression and anxiety, or anger or frustration. And this is currently, we're trying to get to the amygdala non-invasively by using a multi electrode stimulator that can generate different kinds of electrical current. And so what we're trying to do is we're trying to use a noisy waveform to kind of disrupt communication and to kind of disengage the amygdala from the salience network, so that basically we can get rid of the emotion that is attached to the salience. We're currently doing the first clinical trial, and I hope that within 1 or 2 months we'll have the first data to see, in a placebo-controlled way, if we use electrical noise to which you can't synchronize, and thereby hopefully break those connections, that we can then tell the brain, look, this is the problem is not behaviorally relevant, so you should not generate a emotion attached to the problem, because it is irrelevant, basically. So hopefully
that's
we can.
a multi-electrode implanted?
No, so this
No.
is transcranial stimulation. So it looks like an EEG cap. So it has 32 different channels. Each of these channels can be independently controlled and fractionated. So you can, the beauty of that system is that you can upregulate one network, downregulate another network. So you can go from basically single target stimulation to network stimulation. We will in the future just target the amygdala in an isolated way as well. But currently we want to break the links to the salience network from a clinical point of view. So, so all this new technology offers us a lot of possibilities to not only try and help patients, but also try and better understand where the mechanisms are gone wrong in an adaptive system. We call it maladaptive plasticity, but maybe it's not. Maybe it's clinically maladaptive, but from an energetic point of view, it might be very beneficial. So how we define maladaptive might depend on which point of view you look at.
And if you, so using that system, so do you think you can have, like, it's going to have to be worn continuously, or you can have a transient, causes noise transiently and have a long-lasting effect?
Yeah, so this is where the clinic comes in. So we know from the clinic that if you do it repetitively, so 2 or 3 times a week for 20 to 30 minutes, that you can have a prolonged effect. The risk, however, is if, let's say, what we do in the clinic is we give them 8 to 10 sessions, and then we gradually taper it down. We don't stop all at once, because then you tend to see a rebound. Just like we would do with medication in the brain, that we don't stop it all at once, we taper it down. And so what we've learned from transcranial magnetic stimulation, which is another form, is that also in transcranial electrical stimulation, you can have a long-lasting effect. Now, this we see not just in the brain, you also see it in the spinal cord. For example, if you use burst stimulation on the spinal cord and you record activity in the anterior cingulate cortex, which is the dorsal part, so the end station of the salience network or the medial network, whichever way you want to call it, and you stop the stimulation, actually you see that the changes are lingering on, which intuitively makes sense. I mean, if something tells you this is behaviorally relevant, then you should not immediately forget it's immediately relevant. So the relevance should stay for a while until you solve the problem. And that's why you can probably get a beneficial effect if you repeat it once in a while. And currently, we use 2 or 3 stimulations a week, and then you can see that the effect does seem to hold for a while. Not immediately, so you have to do at least 6 to 8 stimulations. But what we do see, if we compare our clinical data, that if you do a little bit more stimulations, so 18 stimulations seem to be better than 9 stimulations. So there is a dose kind of effect, which we know also exists in transcranial magnetic stimulation. Now, intriguingly, from implanted patients. So I've also implanted patients within anterior cingulate cortex directly, so putting electrodes in the brain on the anterior cingulate cortex for alcohol addiction, that if you, after a couple of years of stimulation, the battery goes empty because, yeah, it's connected to an internal battery. And when the battery goes empty and you've been stimulating for a couple of years, actually the effect seems to linger on for years. So their electrical and magnetic and implanted electrical stimulation seems to, at least at the cortical level, seems to induce some kind of learning or longer lasting plasticity, in contrast to when you implant an electrode, for example, in the subthalamic nucleus or the globus pallidus internus. If you stop those stimulation within seconds to minutes, the symptoms come back. So there doesn't seem to be the same learning capacity in those deeper nuclei as you have at a cortical level.
Very old, as you know, a very old treatment for drug-resistant depression was electroconvulsive shock, right? And that, you know, is a very severe, dramatic stimulation. And one of the theories for that is that we know that there's this neurotrophic factor, BDNF, brain-derived neurotrophic factor. And we know it's upregulated a lot by ECT when neurons are really active, but also by other antidepressant things like exercise, physical exercise.
Yeah.
Do you think there's a role for BDNF and kind of plasticity, reorganization of synapses?
Yes. So we know, for example, that people with BDNF polymorphisms, actually some of them don't respond at all to transcranial electrical or magnetic stimulation. So there certainly is an involvement of BDNF in the mechanism of action of those electrical and magnetic neuromodulation approaches, because polymorphisms determine how well you respond to it.
Yeah, it's very intriguing. The problem with animal models is, you can tell whether an animal's responding to acute pain, but the suffering's a little bit harder to evaluate. And then, of course, so I think, you know, the way you're doing it makes a lot of sense. These are all, the side effects are pretty limited. And, you know, it's safe, in other words, what you're doing. So I think this is a case where going directly to the human makes sense. Of course, if you want to understand basic science and what's going on, I guess you could do studies. I don't know how you do this. You could get cerebrospinal fluid. I don't know if that's going to help you at all, but you know, try to get some window into the neurochemistry in the humans. That's kind of
this has been done. So this has been done. Yeah. So we know, as you suggested in the beginning of our nice discussion, when you have a wound, for example, you get a local inflammation, and this inflammation might actually be transferred to the DRG, and then in chronic cases, it goes to the dorsal horn, and actually from the dorsal horn it goes to the lateral and the medial pathway all the way to the cortex. And we know that because when you use a TSPO scan, so a PET scan that looks at microglial activation, you can see those changes in the medial pathway and the lateral pathway. So which means that it goes all the way from the periphery to the brain in the chronic pain state. Now these when you put a spinal cord stimulator and you activate it, then you do a lumbar tap and take CSF, then you can see that there is cytokine changes that are associated with an anti-inflammatory state induced both by tonic and by burst stimulation. So probably one of the mechanisms of action is that we're actually treating the neuroinflammatory state, which is associated with chronic pain. But we know it's also associated with depression, with chronic fatigue, with anxiety, so with a lot of other pathologies. And that's where we might actually have something that one of the mechanisms of action, apart from its neurological component, might be that we're modifying astrocytes as well as microglial cells and producing anti-inflammatory cytokines rather than pro-inflammatory cytokines. And this might be the reason why, after a while of stimulation, actually we see a long residual inhibition effect. So there is certainly a lot more that we need to understand of what we're actually doing. But we see clinical benefits, and we're just trying to figure out what's happening. And that's where animal work can be crucially important.
I had, in a previous episode of this podcast, I had as a guest Kevin Tracy, who I'm sure you must have come across, right? And so he developed this, it's directly related to what you just said about this like inflammatory reflex involving the vagus nerve and the afferents. What about vagus nerve stimulation for chronic pain? Has that been tried?
Yes, yes. So vagal nerve stimulation is intriguing in that it does a lot of things. The problem is that we don't very well understand how it works. And as you might know, there is this kind of popular theory of Stephen Porges about of the polyvagal nerve, where depending on whether you look at the unmyelinated C fibers or the beta fibers, you might have a different response. Where his claim is that when you activate the myelinated fibers, you have the vagal nerve that is involved in social interactions and rest and digest state. And then when you activate the C fibers, the animal feigns as if it's dead in an extreme situation. And this might be related to syncopes in young people who see their favorite rock star coming up. So it has been linked to certain pathologies, and it has also been, people have also tried to link that to different disease states that are being treated. For example, we know we can treat psychological pain or depression with vagal nerve stimulation. So physical pain also might reduce because of its anti-inflammatory mechanism. Now, very recently, there is, well, not recently, there is actually a relatively old paper that shows the vagal nerve, strangely enough, also has a sympathetic component, not only a parasympathetic component, which is what I was taught in medical school.
Right.
Vagal nerve is parasympathetic and that's it. Now, there seems to be a sympathetic component, which makes sense because if you activate the vagal nerve, you see activation on fMRI and PET scan, not just in the nucleus tractus solitarius, but also in the lucus coeruleus, which is the starting point of your noradrenaline pathways in the brain. So then the question becomes, in general, there seems to be a kind of a pro-inflammatory response to the sympathetic activation. So sympathetic activation, it might be an inverted U-curve profile, but certainly when you activate it, it seems to have some pro-inflammatory states and the parasympathetic predominantly an anti-inflammatory effect. But ultimately, it's just like in pain, it's a balance, and you need to balance the correct amount of parasympathetic and sympathetic activity for which the vagal nerve is ideally suited. However, we don't know exactly yet with what language or what stimulation design we have to activate which fibers. And this is where animals could be very helpful, so that it could teach us, look, if you want to activate a little bit more those C fibers, just increase your pulse width to over 1,000 microseconds. If you want to selectively activate your A beta fibers or A delta fibers, use this stimulation design. And only then will we be able to fully elucidate the full potential of vagal nerve stimulation, which I think is tremendous, because from an evolutionary point of view, we've got two systems. We've got the sympathetic system that says do something, and then the parasympathetic system that says, well, you don't have to do anything, you can rest, digest, and restore now, so you can save energy. Or you do, and these, from an evolutionary point of view, further evolved into, so the vagal nerve with its central components basically evolved into the default mode, and the sympathetic system evolved into the salience network, as well as the central executive network and the emotional network. So it's normal that the balance that we look for in the brain is also present at the lower level, but even inside one nerve, and that's very intriguing. It means it's a gold mine for researchers who are interested in trying to modulate both physical and psychological pain.
Yeah, so now I'd like to talk about a case study myself.
Yep.
So through my life, I've had these pain issues, right? And then I had this accident. It's been 4 years ago, mountain bike accident. I had to have 3 surgeries, and I still have this chronic lingering pain, and I've got some peripheral neuropathy that's kind of strange. So I went to my neurologist colleague at Johns Hopkins,
Mm-hmm.
and he worked me up. We did so for peripheral neuropathy, they do conduction velocity, right? Which
Mm-hmm.
is, for me, was fine. But then they did skin biopsy. They take punch of your skin and look at the density of the fibers. And so the density of my pain fibers was normal, but they had an abnormal morphology. They go like this instead of straight.
Yeah.
So anyway, we did genome-wide exome sequencing on my DNA. I have a missense mutation in a voltage-dependent sodium channel, NAV 1.9, that's highly expressed in nociceptive neurons, the neurons that convey pain. And then myself and my neurology colleague at Hopkins both knew Steve Waxman at Yale.
Yeah.
And he's like the world's experts on these, genetic. So anyway, so I'm a neuroscientist, he's a neuroscientist. So he was kind enough, he had one of the people in his lab, he hadn't seen my specific mutation. It's a specific 1 amino acid change in a poor region of the channel. And he'd seen a couple patients that had mutations right adjacent to where mine is. But anyway, he had the person in his lab make my specific mutation in the DNA encoding this sodium channel. And then they expressed it in cultured dorsal root ganglion neurons and recorded from them. And the bottom line is I have a lower threshold for my neurons to fire because of this sodium channel mutation.
Okay.
So I have this chronic pain issue that I guess partly, initially anyway, a lot of it has to do with this gene mutation, but undoubtedly, I've got central issues going on too. So if I were to come, hypothetically, if I were to come to your clinic with this situation,
it depends on where.
Would you treat me any differently than anyone else with chronic pain? Probably not.
Well, the problem is, as far as I know, there is no drug that specifically works on those NAV 1.9 channels.
No.
Menthol might influence it, but of course that's well,
so what helps? What does help is duloxetine is a serotonin norepinephrine reuptake inhibitor. I'm pretty sure that does seem to help, but that's really the only thing that's
Yeah.
getting.
And so where is your pain exactly?
It's in the sites of my surgery in my groin and then both of my feet.
Okay. So if it's both and if it's in the groin, then then in general, well, first of all, if you would come to the clinic, we would start with a traditional clinical examination like the neurologist has done, and then we would do an EEG to see predominantly whether your pre-general anterior cingulate cortex, so your descending pain inhibitory pathway, is deficient in either beta or gamma activity, meaning that it just doesn't do its job. So whether the pain you have is due to a decrease of pain inhibition or whether there is an increase in activity in the somatosensory cortex and the anterior cingulate cortex. So then you can compute that balance, and we've done that. So when you take on an EEG, you take the current density, which is a measure of activity, and you just make the ratio of the dorsal anterior cingulate and the somatosensory cortex on the pre-general anterior, so the pain inhibitory pathway, which we double because, of course, there's otherwise it would be. And if it's 1, there is no pain. If it's over 1, there is pain. So there is some kind of measurement for this pain. Now, if we see this pain inhibitory pathway is deficient, then we would target that with different products, because the problem is that the pain inhibitory pathway has at least 4 different neurotransmitters involved, and now we're not even talking about the sodium and potassium and calcium channels. But so we start by treating it with the different neurotransmitters. So I usually, if of course that shows this deficiency, I usually start with a combination of flupentixol, which is a unique drug that blocks your dopamine D1 receptor. So it basically defocuses the brain from the relevance of the pain, and then we combine that with a very low dose of a tricyclic antidepressant, because they work on your dopamine, your noradrenaline, your serotonin, and your opioids, which are all part of your descending pain inhibitory pathway. This we combine with extremely low dose of aripiprazole, and aripiprazole is very intriguing because it has the right balance of serotonin receptor modifications that activate predominantly the descending pain inhibitory pathway. And if you take just 2 milligrams, it can sometimes do the trick. Now, of course, if you have also co-activation of your somatosensory cortex, then that would modulate it, the treatment a little bit. But to go further, so now we're already modulating your dopamine and alpha-1 receptors. That's what the flupentixol does. We're modulating your serotonin receptors via the aripiprazole, and where sometimes we add a low dose of naltrexone because it blocks your opioid receptors. But if you use low doses, first of all, it has an anti-inflammatory capacity, and second of all, it upregulates your opioid system so that it becomes more beneficial. Now, of course, using an analogy, I'm not a basic scientist, and as a neurosurgeon, I'm allowed to make to simplify things by analogies. If you've got a car that goes too fast, or overdrive of your pain input and balance to the pain suppression, then there's 3 ways we tend to slow down our car. We press the brake, that's our GABAergic system, I assume. We shift back the gears, that's what we do with our dopaminergic, serotoninergic, and noradrenergic influences. And then we release the accelerator, which is your specialty, that's the glutamate. So now what we tend to do in the car is do all at the same time. And so therefore, you have to add a little bit of GABA A, which and I tend to use clonazepam, but at a very low dose, 0.5 or less. And to release the accelerator, we use perampanel, which is an AMPA blocker. So then you've got the combination here of doing exactly what you would do in a car that's going in overdrive, but translated to the human. And if you use very low doses, that can sometimes give remarkable results. Now, let's assume it doesn't do anything. We've done we've tried everything, it doesn't do anything. Then the second step would be to say, okay, well, for the pain in the groin, if that is really very incapacitating, there a DRG stimulation would be optimal, because with DRG you can get down to the nerves that go to the groin way better than with the spinal cord stimulator. And if you say, I also have pain in the feet, then you put also in the same surgery, you put, instead of putting, so for the groin, you would put an electrode on L1, the DRG of L1. But if you say, well, I've got pain in my feet at the bottom, S1, then you would put one on S1 or L5, depending on where you feel the pain. And so you can tailor the treatment surgically to where you feel the pain. Yeah. And then, of course, it depends. If you only have painfulness, and you say, well, I've got painfulness, I don't suffer, then tonic stimulation will be fine. If you also suffer, then, of course, you would add then you would preferably use burst stimulation, right, because we know that can also modulate then the suffering pathway. So it depends. If you would come to the clinic, we would go step by step. First medication. If that doesn't work, to neuromodulation to see if we can improve your pain. But of course, it all depends on whether you suffer or not. And we did a study which is intriguing, together with Professor Plazier from the neurosurgical department in Hasselt in Belgium, and we looked at I think 170 patients who came to the neurosurgical clinic for pain. And we asked them to fill out a numeric rating scale, some questionnaires related to suffering, like the pain catastrophizing scale, the pain vigilance and awareness questionnaire, etc. And then also disability questionnaires, like the Oswestry Disability Inventory and quality of life questionnaires. So we had, out of 300 and odd patients, there was, I think, 170 who had all the questionnaires that filled out correctly. And we did a statistical cluster analysis to look at all the different groups. And the intriguing thing is that we found 3 groups. One group had a numeric rating scale of painfulness of 5 or less. Suffering questionnaires were normal. Disability questionnaires were normal. So there seems to be kind of a threshold of around 5-ish on a numeric rating scale from 0 to 10, where if you go below, you feel painfulness, but you don't suffer. And then the second group was the one who had 6 numeric rating scale or higher, abnormal suffering, but normal disability. So they have painfulness and suffer, but they can still function. They don't have disability. And then the third group had a painfulness of 7 or higher, and they had a disability and suffering. So there seem to be kind of 2 thresholds. If you go over 5, you start suffering. If you go over 7, you also start having a disability, which also means that if you look at it from the other side and you treat it, the first thing to improve will be the suffering, because you have to drop the pain below 7 and the suffering will improve. But if you want to, the disability will improve. But if you also want to treat the suffering, you have to drop below 5, below 6, but probably below 5. So, then you can say, well, is there only an indirect effect of suffering improving with enough or sufficient painfulness reduction? But there was a study performed in the US where they looked at burst stimulation, because burst stimulation can reduce the painfulness better than tonic. So on traditional, the patients that we implant, of course, are the ones with numeric rating scales of 7 or higher, because they have suffering and disability. And patients come to see us not because they have painfulness, but because they suffer and have disability. With tonic stimulation, on average, based on a meta-analysis, you can reduce the pain from 8 to 5. So you're really at the edge of where suffering can improve or not. Now, with burst, you reduce the pain to 3, which has been shown in a meta-analysis. Now, so you can say, well, this is actually, the suffering improves because you drop it below 5. And this could be an explanation. However, in this American study on 269 patients, what they saw is there was a subgroup of patients who improved in their suffering, the pain catastrophizing, without any improvement on their painfulness. So here the suffering goes down, but the painfulness does not go, which you can only explain by a direct effect on the suffering pathway. So it's probably a combination of both. So I think that what burst and tonic have in common is that they drop the pain from 8 to 5. And because you also improve the suffering, or you take away the salience of the pain, you drop another 2 points.
Yeah, that makes sense. Interesting. Very interesting. This is all very exciting work. Let me see if I had anything else. I may follow up with you on this and talk offline.
Yeah, that's fine. That's fine.
Let's see. Oh, yeah. Yeah. The parahippocampal region.
Yeah.
So we didn't talk about executive function or the executive network, right? But okay, so the brain's organized so that our sensory inputs, eyes, ears, pain, touch, taste, all this information funnels in out to the hippocampus, which is important for the establishment of short-term memories, remembering things short. And so you got this pairing of different sensory inputs, vision, sound, so we do language, and it kind of converges on hippocampus. And the parahippocampal region is, as its name implies, right adjacent and has connections. Can you talk about briefly, and I think you worked on this mostly from, you work both pain and tinnitus.
Yes. So the parahippocampus is a very intriguing part of the brain, and the way we try to explain it is from a Bayesian point of view. So I'm in the camp of the believers of the Bayesian brain, which basically states that our brain constantly makes predictions about what it's likely going to encounter, considering a certain intention and in a specific context. And exactly like you say, so our brain makes a prediction, and then it wants to know, is this prediction going to be right or wrong? Now, if the prediction is right, then it should look for confirmation via the senses, so via vision, via sound, via touch, etc. And it might use some form of abductive reasoning, or what people would call a duck test. If it flies like a duck, it quacks like a duck. If it behaves like a duck, it's most likely going to be a duck. So this information has to come somewhere together to be unified into one percept, but also into a confirmation or a disprove of the prediction. And this is probably where the hippocampus is very relevant, because the parahippocampus encodes what you could call context. And the context is ultimately what drives our perception. Because if I give you a cold stimulus in a hot day, you might perceive this as nice, but if I give you exactly the same stimulus, the same coldness, in a freezing day, it might be actually very unpleasant. So the context determines how we perceive the same stimulus. And this is where the parahippocampus is very, very much relevant, in the sense that it determines how we're going to perceive a certain stimulus from a contextual point of view. And it's ultimately the context that will also drive the prediction. In this context, this is what's going to happen. or this is what's going to be most likely. And this can sometimes go wrong. For example, in post-traumatic stress disorder, if you are, let's say you were raped and the man was wearing a specific perfume, then that becomes part of the contextual information. And based on a statistical overfitting of the model of the world that you have, then this only the perfume might already trigger a hyperarousal in that person, even though normally that perfume should not do that. But because it becomes linked to the unified contextual percept, it triggers already the percept that it might actually be dangerous and therefore create a hyperarousal. And so this is where we are now also trying to see, should we build a stimulator that disrupts the parahippocampus from the auditory cortex and from the posterior cingulate, the default mode, to treat tinnitus, but the same for pain. So should we disrupt the contextual information, the parahippocampal contextual information from the pain network, because we know that the context determines the painfulness. For example, Beecher studied this in soldiers after the Second World War, and 80% of the soldiers who came back from the front line, I mean, really the front line where they were potentially going to die, and they had atrocious wounds, but 80% denied painkillers. I don't feel pain. And of course, this makes sense from an evolutionary point of view. Even if you shoot a bullet through your leg, and that's going to impede you from running away from life-threatening danger, then that's not going to be beneficial. So in extreme situations, you don't feel pain. The same stimulus, depending on the context, like in sadomasochism, could be perceived as pleasure. But the problem is if somebody who enjoys sadomasochism hits his finger with a nail or her finger with a hammer, it will cause suffering and it won't be perceived as pleasure. So the context determines how we perceive. And this is where the parahippocampal area is crucially important. And that's where it becomes a very nice target for neuromodulation, because if we can change the context, the contextual influence, then we change the percept.
Yeah, that for me, when the pain was really bad after I got those surgeries and stuff, and I couldn't concentrate very well, but I found playing chess with, if you have to focus your attention on something, you don't, you kind of, your brain excludes any of this pain and suffering signals. So it's kind of a distraction type phenomenon.
Yes, because in this context of playing chess, just like the soldier in war, the pain is actually irrelevant because you have to survive. When you can focus enough on the chess, then the pain becomes irrelevant to the context, and it won't take the trigger away, but it will modify the percept of it.
In chess, I'm trying to keep my king from being killed, not
from
myself.
Being killed, basically.
I'm looking out for another individual. This is so fascinating, such fascinating work, extremely important for humans. Chronic pain, we didn't talk about tinnitus. I'll put some links to some of your work out, and you've given multiple lectures on tinnitus. I'll put some links to those, which is also affects a lot of people. Actually, I looked that up. I was surprised. At least 20% of people will have tinnitus, right? And is it age related often too?
Often, yes. So there is a correlation with age. So there is the prevalence of tinnitus does increase unfortunately, does increase with age, because there seems to be a strong link to hearing loss, which of course is then from a Bayesian brain point of view, you can say, well, the brain knows it should get input, but the input doesn't arrive, but it predicts it. So you get a prediction error, just like in pain, like in phantom pain, and therefore the brain kind of says, well, better safe than sorry. So I will make the sound, or because it might be of relevance, and therefore the sound is being generated, even if it has no function or no meaning. It's kind of a better safe than sorry approach from the brain.
Yeah. Okay, well, I appreciate you taking the time for this. I enjoyed our conversation a lot, and I'm glad I invited you. It gave me a chance to read up on some of this work, which I hadn't, really noticed before, even though I'm in chronic pain. But
Yeah, well, there is of course, clinicians look at pain different than basic scientists, and but we do need basic science and actually even philosophy, because that allows us to make some of those stupid analogies that we tend to use a lot. But it helps to think, and I do believe strongly that the collaboration between basic scientists and clinical people is extremely important.
absolutely, I agree 100%. How long are you going to be in Belgium?
Till tomorrow. Tomorrow I'm going to Italy.
Okay, and your sons are in New Zealand, is that right?
One son is in New Zealand, and one son is in Belgium doing yeah. So I've got because I'm 1/3 of the time I am in New Zealand, 1/3 of the time I'm in Belgium, and 1/3 of the time I travel, more or less. So I yeah, I've got the good luck to be able to spend some time with my son when I'm in New Zealand, and with my other son when I'm in Belgium.
So well, it's nice. You can go. So what, it's it's springtime now in New Zealand, right?
Yes, yes.
Right. So you spend you go from southern to northern, you avoid Belgium in the winter?
And in the ideal world, that would be the case. But no, I tend to come back for Christmas to spend it with family, and it really depends on when there is conferences and when there is.
Yeah.
So
Okay.
yeah, so summer can be any time, and winter can be any time, because I travel up and down all the time.
Yeah. Okay. Have a good, I guess, fall. It's fall time now in Belgium.
Yeah, yes, it is. And
Okay.
I thank you very much for a wonderful discussion, and enjoy
Okay,
the
Dirk.
rest of your day. Bye, Mark.
Okay. You too. Bye.